Hey everyone, good morning. If you can hear me, go ahead and put something in the chat if you don't mind. Looks like we got about 22 people watching right now, which is most of the class. Perfect. Yes, good morning. Nice to meet all of you. It's a little one-sided, but that's okay. It's kind of the nature of life nowadays. I'm gonna wait just a minute or two and get started then. But if you have any initial questions you want to ask, feel free to go ahead and pop it in the chat. It'll be a bit of a delay, just by a couple of seconds, but I like to respond back to those in kind of real time, so that's totally fine. And then also record these and then post them up, so you'll have a link you can actually go back and watch this as well. So yeah, so that'll be available to you. Yes, good morning to you all. If anyone's watching in a group, could you let me know? I'm just trying to get a rough estimate of attendance, and so I'm sure some of you might be roommates, and so you might be doing like a 2-for-1 or more potentially. It's good morning to you all. 19. Yeah, since I'm recording, I'm gonna go ahead and just start recording this. Then we can go ahead and get started here. So, yeah, so welcome to Principles of Clinical Pharmacology. My name's Dr. Adam Wood. I'm going to be taking you basically through all the pharmacy curriculum here at Advent Health. And so I just wanted to get in terms of talking about the course a little bit, sort of setting us up, and then we'll get into the actual first lecture, kind of hit the ground running a little bit. So everyone should have available to you should have the actual Canvas course. I think you all got in before I did, which was kind of fun. I went to go set up the course, and I didn't have a course to set up, so that was fun. But regardless, we're here now. You can see the semester schedule in terms of everything here. So as far as I know, we're going to be doing this, via distance for at least the summer, and obviously in the fall we'll figure that out based on how things are going. But we'll deal with it as it comes along. And you can get a rough estimate of kind of how the course is going to go in terms of exams and whatnot. I need to find out if the exams are going to be held during class time or not. That was something that we talked about. So that's somewhat of a TBD, so just be aware of that. There's also going to be a few assignments, which I'll talk more about as we move forward. So anyway, so getting into the actual course itself. As I mentioned, we will be recording these, so that way I can post them up and you can go back and watch these. Students do appreciate that because the material can be a little dense. I have a tendency to talk a little fast, as it were. So sometimes it's nice to go back and you can slow me down, you can speed me up, whatever you want to do. Actually, I'm a nice natural remedy for insomnia, so you can watch these before you go to bed and you shouldn't have any more sleep issues, right? Another thing you'll see here is going to be the syllabus, so that'll be good to give you some information in terms of what you're going to be graded on, what the percentages are, and all of that. I can probably just pop that open real quick here, just so you have an idea of, actually. So going down, you can see how your grade's going to be calculated, because that's important. You want to know how that's going to be done. There was 4 homework assignments. That's been now condensed down into 3, and so I'll talk about that in a little bit. But you can see how the grade's sort of broken down. This is a short semester, so the tests are going to come pretty quickly. I think like the 3rd week or something is our first exam. Keep in mind that 3rd exam is going to be cumulative, so it's going to cover the entire course. So just FYI, not to scare you, just to let you know that that's going to be coming up. And that's good, though, because this whole course sort of builds on itself. So everything is going to be reliant on what we learned from the week before. So don't feel like it's going to be a lot of really disparate information being pulled together. It's all pretty consistent here in terms of building on itself. Getting into, excuse me, one other thing that I wanted to make mention of here is I want to try to encourage interaction as much as I can. And this is difficult let's see, the test will use Exemplify or Respondus Browser. That's a good question. I'm not sure if they're switching over. I'll have to check with Dr. Murray to double check with that. So again, more to come, but you got a couple weeks still we have to worry about that for our purposes. So anyway, getting into looking at this, one other thing I want to do to try to encourage interaction is one, you can totally post up questions in the chat here. I want to make sure that you always feel like you can ask questions, and my intention is to never make anyone feel little or not intelligent when you ask a question. I've had some very off the wall questions asked before, and everyone's question is treated the same. So definitely feel free. Don't hesitate, right? Ask questions. It's also nice if you ask questions during class time, because that does help to benefit everyone, because I guarantee you're not the only person thinking whatever it is you're wanting to ask. But as a backup, I do include this sticky board here, which you can see. And so this is a nice way to sort of anonymously post questions. And I have it up here, and you can test it out. You can put like a little sticky note. You can say whatever you want, question, test, whatever. But you can post questions here, and this is anonymous. I don't know who asked it, but it's a good way for students to, be a little less hesitant to post up questions, and we can talk about things. I'll usually look at this towards the end of class. I'll usually, then discuss everything there. So don't worry if this doesn't get answered immediately. It will eventually. The other thing too, it's nice, I know I'm sure other professors are using Zoom or whatever other platform that's there. I like to use YouTube because, one, I think the audio quality is better on your end. I typically don't have a lot of student interaction anyway when I'm doing Zoom sessions. Most people have their cameras off, and I'm just talking to myself anyway, so I don't really get any benefit from that. The nice thing too here though is that you can pause my stream and then just come right back. So that's a nice thing if you want to take a break, go to the bathroom. I'm not going to know. I don't really care. Not a big deal. I'm probably not going to build in any breaks into this, because then it's kind of awkward me just sitting here for 10 minutes. It doesn't make a lot of sense. So I'll probably go to about an hour and 40 minutes or so, just to count in for, 2 10-minute breaks or whatever. So, but don't hold me to that. Might go a little shorter, might go a little longer. We'll kind of feel it out. But, might have my time until 10 roughly. So, getting over to the PowerPoint, hopefully everyone has access to that. If not, certainly let me know. And yeah, so basically I want to talk a little bit about myself, about the course and all of that. As I mentioned, my name is Adam Wood. I'm a pharmacist, and you may be thinking, well, what is a pharmacist doing teaching in a PA school? I've actually been doing this for quite a while. I think this is like my 6th year teaching in PA education. I started off as an adjunct professor, and then now I do this full time. So I'm adjunct for Advent Health, and I'm actually full time over at Nova Southeastern, right across town. And so, a lot of you may not really know what a pharmacist does, and I'm sure that's something we'll talk about during this class, and kind of talking about the role of the pharmacist and how we work as part of the healthcare team and helping you to take better care of your patients when it comes to the medications. I'm sure a lot of people, when they think about pharmacists, they probably think about the person you see at CVS, you see at Walgreens, etc. And that's a big role for pharmacists to play. But I'll also tell you about some more clinically oriented roles as well, and that's mainly what I do. You'll find that pharmacists are working at hospitals, and we round with providers, and we make sure that medications get delivered to patients appropriately there too. And that's mainly where I work. So just to give you a bit of my background, I went to school at UF and there's a Jacksonville campus up there that I went to for pharmacy school. And then afterwards I ended up doing a 2-year fellowship, and that was based in emergency medicine and toxicology. So I actually did it up at the Poison Center there. I was working in the ER, and actually got to be certified as a toxicologist. So if you look at my credentials here, you see the Pharm D, which means it's not an agricultural degree. It means Doctor of Pharmacy. And then there's a DABAT, which basically means I'm part of the American Board of Applied Toxicology. So I also still work with the Poison Center, and I take call for providers there a couple times a month. But after that, I needed a job once I finished fellowship, and so I ended up moving down to Orlando and actually started off as the first ER pharmacist working at Nemours Children's Hospital. And I actually still work there to this day, about once a week or so, once every couple of weeks, as part-time, because I'm teaching full-time now. But it's nice because I still get to stay clinical. I still get to see things out there in the world and then bring them back and talk to you about it, which is really nice because it helps to make things pretty clinically relevant. You may be talking about a drug and you're just like, okay, I don't really understand what he's talking about, but if I can link it back to a specific patient that I dealt with dealing with that drug, that helps to drive it home and I think solidify it in your mind a little bit better. So yeah, so basically, you know, my main interests are in emergency medicine. I like toxicology quite a bit. That's mainly what my passion is. And then I also do a lot of pediatrics, obviously, because again, kids get into poisons all the time. In fact, the most exciting thing that happened to me over the quarantine so far is actually my 2-year-old ended up eating a bobby pin, so it was considered to toxic ingestion. So she's fine now. She passed it. No issues, but still. Speaking of that, I do have 2 little ones. I have a 2-year-old and a 4-year-old. They can be rambunctious. So if you hear any screaming in the background, I apologize on their behalf. They don't know good streaming etiquette, but I'm trying to teach them, so it's okay. You know, life is what it is. So, an overview of the course, again, this is going to be a introduction to pharmacology. This is going to lay the groundwork for Pharm 1 and Pharm 2. And in terms of difficulty between these courses here, you'll find this course is you may not think it in while we're doing it, this course is fairly straightforward and a little simpler than it will be once we get into Pharmacology 1 and 2. You're going to find that this is just the basics in terms of like, what is a drug? What does it do in the body? How is it processed through the body? All of that. You have to know all of that stuff in order to get into actually talking about the Pharmacology 1 and 2. And so this course is kind of like learning a new language in terms of like, well, how do I even like learn about a drug? And this is what we're going to do here. So certainly Pharm 1 and 2 is going to pick up in complexity once we get into the specific drugs here. I'll also talk a fair bit about different drug examples, but I'll keep it relatively surface level so that way I don't kind of lose you in the weeds, as it were. It's 1 credit hour. There's 14 hours of instruction, so we have 7 meetings we're going to have. Obviously, this is the first one. And we're going to have 3 homework assignments. And so basically, one of those is going to be a drug information assignment. I did post that up, and everything should be visible to you now if you look in the assignment section of the course. Or if you look at from that front page, you can get to it as well. 3 assignments. One's going to be a drug information assignment. You have all been randomly assigned one of the top 200 drugs. When I say top 200, it's like the most prescribed drugs in the US. You've been randomly assigned one of those, and you're going to have a set of questions you're going to answer. And as we go through these different sections here, you can begin to answer those questions, right? I want you to use reputable drug sources for those, and we'll talk about some examples of those in just a little bit. But basically, go through, answer those questions as we sort of hit on those topics. And so you can look to see what drug you've been assigned already. So if you have any questions about that, you can let me know. We'll talk more about that as the due date's coming up. The next assignment is going to be related to drug dosing calculations, and so I want to make sure that you guys can do the basic math that is needed in order to do things like drug dosing and to do things like unit conversions and whatnot. So that's going to be taken as a quiz. That quiz is also available, but we won't talk about that more till the 4th section of this class when we have a whole section about doing that. So don't fret over that too soon. That is a repeatable quiz, so you can take that as many times as you want in order to improve your grade. It's just a means of making sure that you can actually do the math and you can figure it out on your own. I have no means of keeping you from collaborating, but I suggest you do this on your own, because it's not going to help you if you get carried through it and then you don't actually know how to do the math, especially when it comes to doing our final assignment, which is going to be a prescription assignment. I'll talk more about that in a little bit as well, but basically you're going to go through and write a few scripts. This is going to be something we're going to do for the rest of Pharm 1 and Pharm 2. All of your homework assignments will be will be prescription assignments where you actually will be given a case and you have to figure out how to dose a drug, how to write the prescription, and all of that. So those are the 3 assignments. Like I mentioned, we'll talk about those later. There are 3 tests, 2 of which are going to be 25 questions. So there's a little bit shorter because there's less material on those, and then the 150 question cumulative exam at the end. They're all going to be multiple choice. They're all going to be 5 answer choices. It should be pretty consistent with what your other tests are in your other courses. Now, I'm not sure what else you've had so far, but they should all be pretty consistent there. And you need a 75 or better to pass, so pretty straightforward. So If you have any questions so far, please post them up in the chat and I'll try to address those as they come up. Otherwise, I'm going to go ahead and get started. About 15 minutes in here, so seems like a good time to transition over and start talking about some of our definitions. Because again, pharmacy is like learning a new language, and so to speak that language, you got to know sort of the basics, right? So getting into some of the definitions here. So when we talk about drug names and some of their classifications here, these are important things to know. So here's an example of ibuprofen. Most of you have probably taken it or seen the drug at some point in your life. And so there's a couple different ways we can talk about this particular drug here, right? So there is the trade name. Trade names are typically going to be trademarked, and so that's what one company will use to market the drug. So if you see ibuprofen, you may see it under the brand name of Motrin or Advil. That's a trade name. That's something that is done by the company, right? The generic name is going to be basically the chemical substance name. That is what gets approved by the Food and Drug Administration, or the FDA. So that's ibuprofen, right? So everyone will know it as ibuprofen. Some people may call it by Motrin or Advil, sort of shorthand. I think it's important that you're aware of common brand names and the generic names. At the bare minimum, you need to know the generic name when we talk about these, because that's sort of like the baseline level that everyone should at least know and be able to identify the drug. If I put a drug on a test, I will always have the brand name in parentheses next to it. So as a means of getting you more familiar with seeing these things, right? So if you've ever heard of the drug Lasix, that's a brand name. But the generic furosemide, that's also something you should know as well, because some people may not call it by Lasix, they may call it furosemide, and vice versa. So getting into the actual pharmacotherapeutic classification, ibuprofen falls into one that's a non-steroidal anti-inflammatory drug, or an NSAID. Basically, the classification is generally going to be based off of the actions of the drug or the mechanism or something like that. And so you'll find that other drugs may fit into this classification as well. So for instance, the other over-the-counter NSAID, naproxen or Aleve, would also fit under this umbrella of non-steroidal anti-inflammatory drug. And it's pretty straightforward. You already know what the drug does just based off that name, right? It's a non-steroid, okay, and it's an anti-inflammatory drug. Boom, I already know two things about that drug already, and that's just based off of the name, okay? Now, what does that drug do in the body? That's where we talk about the mechanism of action, and every drug will have a mechanism of action. We may not know what the mechanism is. Sometimes we have drugs that we just say, I don't know, it just works, right? So you would think that, you know, medicine is to the point where we just know everything, but we honestly don't in a lot of cases. But there are quite a few drugs we do know the mechanism of. That's the MOA here. So as an example here, ibuprofen itself blocks the enzyme cyclooxygenase. They'll decrease prostaglandin synthesis and all of that, and that will lead to an anti-inflammatory action, right? Now, you don't have to memorize all this for this class in particular, but we will learn this as we go forward into Pharm 1 and Pharm 2, and so you'll be able to make heads and tails of this as we go forward. If you don't understand this right now, don't worry about it. We'll get to it eventually. Just illustrating what a mechanism of action might look like for a particular drug. You need to know these, because if you don't understand what the drug is doing in the body, then it's harder to understand like how it's affecting the disease state process. It's harder to understand drug interactions or adverse effects and all kinds of other things, right? So it's the mechanism, and then you get into the indication. And so here are the things we actually use the drug for. So we can use ibuprofen as an anti-inflammatory to actually decrease inflammation if you have an injury, for instance. We can use it as an analgesic, so it works to decrease pain sensation, and an antipyretic, so we can use it for fever, right? So you'll have sort of the classification for what the drugs fall into. You have their mechanism to know what they're doing within the body, and then you'll have the indication for kind of how we use them, right? These may be approved by the FDA indications. Sometimes we use things off-label, which means we're using it for things that it has not been approved for, but we may have scientific evidence that shows that it is effective for that. So that's something you may hear. If you hear off-label use, that's kind of what we're mentioning there. So pharmacology is basically just the study of the reaction of drugs in the body, including interactions between drugs. I'm sure many of you have family members, or you yourselves might be on multiple medications, and any of them could potentially interact with one another. And that's a huge source for medical errors, for adverse drug reactions that people experience. And that's another big thing that we'll talk a lot about as we go forward. But that's basically what pharmacology is, and you could then break that down into two further fields. So there's pharmacodynamics and then the pharmacokinetics between the two. Pharmacodynamics is basically what the drug does to the body, right? And so this is mainly concerning itself with the mechanism of action of the drug and what it does to the body itself, right? And we're going to talk about things like relationships between concentration of and the effect that it has on the body. So for instance, if I give you 200 milligrams of ibuprofen, you may get a certain level of effect. But if I were to say double that and give you 400, you should get more of an effect, right? So more is more, essentially. And so that's what pharmacodynamics will talk about. I'll talk about that relationship there. But you may find the effects are not just therapeutic, they could also be toxic, right? So you may have heard of things like ibuprofen causing stomach bleeds, for instance. That is a toxic effect of that drug that we are well aware of, but could be related to things like the concentration of the drug, how long someone's on it, etc. All of that is related back to the dynamics of the drug, the pharmacodynamics, right? And so to distill that down, you can basically see what the drug does to the body or how it affects the body. That's pharmacodynamics. So here's an example. I like to use ethanol as an example because not everyone has been on a prescription drug before, but most people have either seen someone taking ethanol or have consumed it themselves. I'm sure all of you are just really upright, upstanding individuals and would never consume ethanol, but maybe in your past you might have at one point, right? Just kidding. But ethanol itself, right? So we're talking about a dose response with ethanol itself. If you imagine 3 different scenarios or 3 different drinking levels, you know that ethanol can cause different effects. So for instance, if you have, say, low dose ethanol, 1 to 2 drinks, for example, you may have some loss of inhibitions. You may have some of that social lubricant effect where maybe you are more likely to talk to someone, right? You may be more likely to say things you would not normally say. That's a low dose effect of ethanol. But what would happen if you were to say, yeah, let me go ahead and take that next shot, right? Now you're getting up into moderate dosing where you're going to see slurring of speech. You may see that incoordination. You may have that ataxic gait and you fall and you stumble and things like that. And then all the way at the really high dosing, which hopefully no one gets to, but some people do, you can see things like syncope. You can see things like respiratory depression, vomiting, aspiration, etc. This is where people can die potentially. But notice here that just one drink's not going to get you there. It has to do with the dose being consumed, right? That's a pharmacodynamic effect, or what that drug itself is doing to the body. So hopefully people can sort of relate to that example there. But if not, let me know. We can discuss more. So next up, getting into the actual pharmacokinetics, this is going to be the flip side. So instead of what the drug is doing to the body, this is what the body does to the drugs, right? So as a drug gets taken in via whichever route, whether it be oral or IV or whatever the case may be, it's going to be moving throughout the body. And we're going to see there's a relationship between the drug concentration over time. There's no drug you just give one time and it sticks around forever, right? Every drug gets eliminated from the body in some ways. And so this has to do with the kinetics, right? So basically there's 4 different sort of phases of kinetics here. There's the absorption of a drug, there's how it distributes throughout the body, there's how it gets metabolized within the body, or how it gets broken down into various byproducts, and then finally how it gets excreted. So we'll talk about kinetics in much more detail later on, but there's basically these 4 different sorts of processes that happen here. We'll get much more into that. But basically, what is your body doing to that drug to get rid of it? Because essentially, the body's going to see it as a foreign material. It's going to get rid of it in some way, shape, or form. And so this is what kinetics is talking about. So let's go back to the example of ethanol again. So ethanol itself, you're going to find it has a very particular type of metabolism that occurs. You may know that the main organ that does a lot of metabolism in the body is actually going to be the liver. And so the liver is able to process alcohol at a certain rate. So let's say we have 2 different types of drinkers. We have one who's alcohol naive, meaning they very rarely drink, maybe once every couple of weeks or a month or something like that, versus a chronic drinker who may be drinking, say, a 6-pack a day, or they're drinking more than that, right? You can find some pretty high, especially when you get into like hard spirits and liquors and things like that. But you can find changes in their kinetics based off the exposure to the drug itself. So for instance, the alcohol naive person may only metabolize, say, 20 milligrams per deciliter per hour. It's about a drink per hour, essentially. But you'll find that chronic drinkers, as they have been exposed to the alcohol over time, their liver gets better at metabolizing. So they actually start to upregulate those metabolizing enzymes. and they can metabolize it 3 to 4 times faster in some cases, right? That's a pharmacokinetic effect. The body has changed how it metabolizes the drug such that it has different parameters, gets excreted or metabolized faster. So that's one example. We'll find some others as we go forward and talk about different drug examples there. So how we could break this down into this chart here, you can see, okay, let's imagine we're giving a dose of drug. Let's say we're giving a drug orally, right? You have a tablet you take orally. You're going to see that the kinetics here are going to be mainly the first portion where we're going to have absorption. We're going to get some amount of drug in that systemic circulation. And what I mean by that is basically the bloodstream, right? So how it's circulating around the body. We're going to find that all the drugs will distribute somewhere into the tissues, right? It just doesn't stay in the blood. It has to get out to wherever it's supposed to work, right? If you have an injury, if you have say you have a sore ankle from working out or something, you want that ibuprofen to get to that site of inflammation, right? That drug has to distribute out there somehow. So there's a distribution phase, and there's also the elimination that occurs here, right? So either metabolism in the liver, excretion through the kidneys, whatever. This whole section here is pharmacokinetics, okay? What the body is doing to the drug. Once the drug actually gets to that site of action, once it gets to that injury or wherever the case may be, whatever how the drug is working, this is where we get into the pharmacodynamics. This is the pharmacologic effects that occur. This is the clinical response, either through efficacy, meaning you have decreased pain, you have decreased inflammation, or from toxicity, say the effects in the stomach causing a stomach bleed, for instance. So that's kind of the delineation between those two. So I want you to understand when we're talking about things like, liver metabolism, that's a kinetic issue. We're talking about how the drug works at the site of action. That's a pharmacodynamic sort of issue, okay? So some other definitions we'll talk about here include pharmacogenomics. This is basically how a person's genetics may change how they are either affecting the drug or being affected by the drug, right? So you can find that patients may have polymorphisms that may make them really good at metabolizing a drug or really poor at metabolizing it. Sometimes we can find these to be pretty consistent in different populations. Sometimes it's totally random. We just don't know who's going to have some of these changes here. This is going to become more relevant as time goes on because we will be able to have cheaper and easier access to some of these tests here. This is already routinely done for certain drugs, but for the most part, you're going to find that when you see patients that react differently to the same dose of a drug, a lot of it could be related to their genetics and how that could be playing a role here. So this is that field of studies looking at their pharmacogenomics. Now, getting to the actual definition of a drug, what is a drug? You may have some idea in your mind of what that is, but basically it's any substance that can bring about a change in biologic function through its chemical action, right? And so I'm going to use this analogy of a lock and key sort of model here in terms of how drugs are going to work. And drugs are the key, right? They're going to be the things that interact with the lock that we're going to talk about in a second. Now, the receptor here is that lock. Basically, it's any component of a cell or the organism that interacts with the drug. You can see here, even though my poorly assembled shapes here, you can imagine that that drug, that key, would fit into this lock in some form or fashion there. You may find that the receptor resides on the cell surface, could be within the cell. You're going to find there's a lot of different targets and things that we can consider to be receptors. We'll talk a lot about receptors as we go forward. But basically, once it's interacted with by that particular drug, it's going to initiate a series of changes, right? It's going to lead to changes in cellular function. It could lead to effects on enzymes. It could lead to changes in coding for DNA, not coding for DNA, but the transcription and translation of DNA into proteins. Has a lot of different effects here, right? Most receptors you're going to find are going to be proteins for the most part. So whether it be enzymes on the cell surface or within the cell, transporters and things like that. I'll show you some more specific examples as we go forward. You could even have DNA being the target itself. So if you imagine things like chemotherapy that we would use to treat cancer, a lot of those actually target the DNA itself of cancerous cells to try to keep them from replicating or killing them potentially, right? And so we're going to find that the receptors play a pretty strong regulatory role here. One of the big things I like to harp on in terms of drug action is that the body likes homeostasis, right? We like to have our resting baseline, go with the flow kind of action here, and the body resists change. So you're going to find that these receptors, they can change their number or they can change their function such that they try to maintain that homeostasis. And so what I mean by that is if you have a drug coming and affecting that receptor, it could cause a change in the number of receptors available because the body's trying to maintain the homeostasis. And that means you get upregulation of receptors to where now you have a whole lot more of them available, or you may actually have downregulation as well. You may have fewer receptors available to interact with the drug. And I'll talk about a lot of examples of how that actually comes up clinically in terms of drug interactions or adverse reactions that can happen due to this change in regulation. So another way to look at this as well is to imagine this model here, the drug being the key, the receptor being the lock here. So here you imagine this is sitting on the cell surface. At some point, the drug, given a certain concentration, will come and interact with this lock here, this receptor, and will form that drug receptor complex. Once that occurs, then you're going to find that the effect downstream is going to happen here. Now, how do we make sure that more of this drug interacts with the receptor? There's different things you could do. You could try to increase the amount of drug here, right? So just like in any kind of chemical equation, if I were to increase the amount of substrate here on the left side, it's going to force this reaction over to the right, and you're going to get more drug receptor complex. This is going to be part of that response or that dose response we're going to see and talk about a little bit later on, probably next week if I had to guess. But again, this is what we're seeing. The downstream effect only occurs once the receptor binds with the drug. So another term you may hear me use is going to be ligand. This is a generic term and is basically any molecule that binds to a receptor. These are usually involved in cell signaling processes here, and they can include a lot of different things. Now, drugs themselves can be ligands because they can bind to the receptor, but lots of other things can do this as well, which is really important. So, for instance, when we talk about neurotransmitters like epinephrine or serotonin, these will be really important when we're talking about cardiovascular function or when you're talking about depression, for instance. How drugs may affect neurotransmitters, they're affecting ligands, essentially. They're going to go down and bind to some other receptor. There's a lot of hormones that are important here, so things like insulin and cortisol, once they bind to their respective receptors, that is also considered to be a ligand at that point. And there's a lot of messenger molecules too, things like antibodies and whatnot. So really anything that binds to a receptor, that's a ligand. Kind of a generic term. Next, we have hormones. Basically, a hormone is any sort of natural substance that is produced in the body and then influences the way the body grows or develops. And there's a lot of hormones we have there. We'll talk a lot about those, especially when things are either going, maybe you're releasing too much of a hormone, causing problems, you're releasing too little of a hormone. But basically, they're kind of the body's drugs, right? So, for instance, if your blood glucose is too high, the body releases insulin to cause the cells to take up more of that glucose into the cells, and that leads to lower blood sugar, right? There's lots of other effects that happen there too, right? Because insulin is an anabolic hormone. It helps to promote growth of muscle and fat tissue and things like that. Testosterone, obviously, we know that is an anabolic hormone. Estrogen, lots of different things, right? So we'll talk a lot about those as we get into their individual sections next semester or the next 2 semesters or so. And then a xenobiotic is basically any chemical compound that's considered to be foreign to the living organism. So giving Advil or ibuprofen, that would be considered a xenobiotic because it's not something that your body would naturally produce. There are things considered to be toxic to the body or poisons to the body. And so there are 2 different terms here. I'll probably use them interchangeably, but there's toxins and there's toxicants. Toxin is basically a poison of a biologic origin. So if you imagine if you were bit by a snake, and again, it's going to be the summertime, people hopefully will be socially distancing from snakes, but unfortunately to Florida, if you're new to Florida, we do have several venomous snakes that live here, so stay away from them. That's considered a poison of biologic origin. It's a toxin. Okay, toxicants are basically anything that are non-biologic. So if you had like lead poisoning, or if you had like a Tylenol overdose or something like that, that'd be considered a toxicant. Okay, and then toxicology is basically that study of harmful or poisonous effects of drugs. And this is an important field, especially if you go and work in the emergency medicine field or the ICU or anything like that. You will find lots of toxicology cases that will come your way, and this is what I specialize in. So I actually work at the Poison Center. I volunteer there, a couple times a month where I take call overnight, and so I get to talk to providers, at 3 a.m. when they have a snake bite come in, or if they have an overdose and they need some help in terms of that management. It's something I do as part of my, extracurricular activities. So next up, we can see here that an agonist is an important concept here, agonist and antagonist. An agonist is going to be anything that binds to and then activates the receptor. Okay, when I say activate, it means it's causing that normal physiologic change that would occur if the normal ligand would bind to it, right? So for instance, if I have an insulin receptor, normally responds to insulin, and then I were to give, say, a pharmaceutical form of insulin, and it goes and binds that same receptor and causes the same effect to lower blood glucose, that's an agonist, right? Because it's activating the receptor. Now, it may bind directly or indirectly. We're not really going to get into the weeds about that necessarily, but just as an example, another example here would be a beta 2 agonist. So if you've ever heard of someone with asthma, or if you yourself have ever been on the drug albuterol, albuterol is considered, its classification as a beta 2 agonist, meaning that it will then activate beta 2 receptors when I inhale the drug, and that causes smooth muscle relaxation in the respiratory tract, leading to me breathing easier. Okay. It's an agonist, it activates the receptor, causing that positive effect there. Now, when we talk about how drugs bind to the receptor site, there's a couple of different things we'll mention here. And so one of the terms we talk about is affinity, or how tightly a drug binds to that receptor. Drugs may have really tight affinity, meaning they like to bind and they will stay bound to that receptor for a long time. Or the affinity could be low, such that it is a very weak interaction, does not bind as tightly there. That'll be important for some of the drug interactions we'll talk about a little bit later on. But just know that things can have a tight affinity, high affinity, bind very tightly to that receptor. They have a low affinity, and everything in between, right? Now, potency, another really important term you want to know this. This is basically the amount of drug necessary to elicit a given response, right? And so we're going to typically find that drugs that are very high potency, they don't really require a whole lot of drug in order to get an effective dose, right? Versus something with a low potency, you're going to need a lot more of that drug to get the same response. And so a good example of this would be some of the opioid analgesics. I'm sure you've heard of some of these, but we have morphine and we have fentanyl. Both of these you may see used very commonly, especially in the surgical setting, but you can see them used anywhere in the hospital sort of setting. Or you may actually see it outpatient as well, depending on if you have chronic pain patients and things like that. But basically, to look at the potency between the two, in order to get the same effect, you'd have to give milligrams of morphine versus micrograms of fentanyl. Okay, so as an example, if I had a patient who was in pain coming into the ER, I could give them an IV dose, an intravenous dose of 5 milligrams of morphine, or I could give them 50 micrograms of fentanyl. And that may be considered to be an equally potent dose between the two, but notice I'm giving way less fentanyl, right? So I have to give very little amount of that in order to get the same effect as another drug. That means it's very potent, has very high potency. Morphine has relatively low potency, okay? So overall, though, what we really care about is going to be the efficacy of the drug. So how well is it able to produce the maximally desired effect? Because again, I could have the most potent drug in the world, but if it's, if I have a patient who's broken a femur and the femur's sticking out of their leg and they're screaming in pain, I give them the most potent drug in the world, but if it's not all that effective and it's not going to do anything for their pain, it's not really that good of a drug, right? So efficacy is clinically pretty important for us because we care what the actual ability for that drug to produce an effect is, right? So can I get your blood pressure under control? Can I get your blood sugar down? Can I do all these things? That's what you really care about. But when you're looking at dosing of drugs, that's where potency comes into it. So when you're looking up a drug dosing and you're saying, well, why is this one dosed in grams and this one's in milligrams? A lot of it has to do with the potency in order for it to produce that efficacy. So as I mentioned, the ability for drugs to produce the desired response, we use a term called equipotent doses to compare those two, right? So for instance, when I use the morphine to fentanyl example, say 4 or 5 milligrams of morphine is equivalent to about, say, 50 to 100 micrograms of fentanyl, right? Everyone's a little different how they react to that, but you get the idea. Another way to illustrate this would be, say, 100 milligrams of drug A is equipotent to 10 milligrams of drug B. Imagine these were antihypertensives, drugs used to lower blood pressure. Drug A would get the same drop in blood pressure as drug B at these equivalent doses. These are called equipotent doses at this point, okay? So the potencies of the drug are very different, but the efficacy is the same at this level. That makes sense. So next up, we'll talk about full agonists. This basically is anything that produces the full response, assuming you filled up all your receptor occupancy. So if I bind up and I have a drug that binds up 100% of the receptors that are available, you're going to get 100% effect out of that drug. Okay, so you're going to get every one of those receptors being activated, assuming they're all filled up. So if I have enough drug in order to actually get that response there. You could also have partial agonists. You could have drugs that bind to it, but may only partially activates the receptor. So instead of getting, say, 100% effect out of that, you may only get 75 or 50% response out of that. And so you may find that even though you would bind up all of the receptors that are available, you're still going to get a lesser effect than you would if you had a full agonist. So imagine that I were to give an antihypertensive. One's a full agonist and one's a partial agonist. Well, if I give the full agonist, maybe I get, say, a 20 millimeter mercury drop in systolic blood pressure. I give a partial agonist at the same dose to fill up all the same receptors. I may only get, say, a 5 or 10 millimeter mercury drop. Okay, it's a partial agonist. You're not going to ever see the same effect as you would out of a full agonist because it's only going to be partially activating those receptors. Okay. So again, just another pictorial example here. Imagine you have a full agonist with 100% efficacy versus a partial agonist where you're only going to get 50%, right? So it doesn't matter how much drug I give, I'm never going to be able to get the same efficacy out of this full agonist because, again, it's only partially activating that receptor. So up next, if you were to look at another way to see this, if you're looking at the response of the drug, right? So you're looking to see what that drop in blood pressure is, for instance, versus the concentration here. You're going to see that the full agonist is always going to be able to get more effect than the partial agonist. Now, one of the things you're going to notice here, and we're going to talk about dose response curves much more in upcoming lectures, but if you notice here, it always plateaus out, right? You think about why it plateaus out like that. Well, that's basically when you end up having all the receptors being occupied. Basically, at a certain point, it doesn't matter how much more drug I give, I'm never going to get any more effect out of it because your body only has so many receptors to be affected by that particular drug. You only have so many insulin receptors or beta receptors or whatever the case may be. Okay, so you'll always notice this peak dose response here, and it plateaus out because that's when you've occupied all of those receptors. So another really important concept here is going to be the antagonist. So we talked about agonist, talk about full and partial agonists. Now we have the antagonist. This is going to be something that blocks or reduces the action of the agonist. And so, for instance, here we have one like a competitive antagonist where basically it's going to sit on this receptor and it's going to prevent anything else from coming in and activating it. Basically, it's like if you were to jam some bubble gum in your lock or something, right? That key can come along and try to get in there, but it's never going to be able to affect that receptor, right? And so that's called a competitive antagonist where basically you're going to have agonists competing with antagonists to bind for that receptor, but you're going to see this is blocking that. I'll show you a good example of that in just a moment. Sometimes you can have chemical antagonism. This is where a drug may bind to another agonist and inactivate it. So you'll see that a lot with antibodies and things like that we can potentially give that will go and bind that up and inactivate the drug. And sometimes you'll find there's kind of functional antagonism. So this is where the drug sort of indirectly inhibits the actions of an agonist. So for instance, if I am giving someone insulin to lower their blood sugar, but then they're also taking a drug that increases blood sugar, you can see how that's going to be sort of fighting one another. You're going to see that they're going to be kind of functionally antagonizing one another, even though you don't have the same sort of competitive antagonist sort of effect here, right? But keep in mind there's no activation of the receptor itself. It's just sitting there occupying it. It's not going to be actually activating it, okay? So another way to look at this would be if you had, say, a natural chemical and a natural ligand that would bind to this receptor here. Here would be an agonist drug that would do essentially the same thing. So if you imagine giving a pharmaceutical preparation of insulin versus the natural insulin that you would produce, the antagonist is just going to sit here on the receptor and prevent anything from binding to it such that you're not going to get that same change in cellular activity that you would expect to see, okay? So just giving you some examples of different types of antagonists. So for instance here, another way to delineate these would be if they're reversible or irreversible antagonists. You're going to find that reversible ones are going to only have effect as long as the drug is around, right? So I like to use the example of ibuprofen versus aspirin. So with the ibuprofen, as long as there's drug in the system, it's going to be there and working. It's going to be blocking the effect of this enzyme cyclooxygenase. If you ever heard of the enzyme COX, that is the shortened version of cyclooxygenase. It's reversible. So once the drug gets metabolized and eliminated from the body, that cyclooxygenase can now start to work again. Okay, versus an irreversible antagonist, they will actually cause some sort of permanent or covalent bond to their target and will, for the lifetime of that target, will be inactivated. So with aspirin, this is actually an irreversible antagonist. Once it binds to cyclooxygenase, that cyclooxygenase is done. It cannot work again until you get rid of it and replace it with a new one. So aspirin itself actually has longer lasting effects than you would see for ibuprofen, which is why you may give aspirin for, say, for instance, cardiac protection to prevent someone from having a heart attack, because it has a long lasting effect and prevents things like platelets from sticking together and causing myocardial infarction, for instance. So those are two different types of antagonists you may find there. But looking at the interaction between, say, an agonist and a competitive antagonist, you can see how they antagonize one another, right? It's right there in the name. So imagine now we're giving an agonist by itself. You see here how it would have this normal sort of dose response curve here. And again, if I were to take this to the extreme, if I were to use that plateau, you can see here how it would end up in the very end. Versus an antagonist, if I were to then add that together, you can see how the efficacy of the agonist is being reduced, right? Because these are competing for the same receptor sites. And so even now, when I get to this point here where I should have 100% receptor occupancy, the competitive antagonist is still trying to occupy those spots, right? And so they kind of are fighting one another to get those spots there. A good clinical example of this would be with the opioids. And so, as you might know, we're in the middle of an opioid epidemic, along with all the other epidemics we're dealing with. But overdose deaths due to opioids are unfortunately quite common, as it turns out. And so the way we combat that is with a antagonist, right? And so here's an example of 3 different drugs. And again, opioids what we normally use them for their analgesic properties, but some people will abuse these for the euphoric properties, right? They feel really good when they take it. Unfortunately, when you get too high of a dose, you start to get things like respiratory depression, you pass out, CNS depression. And so that's where things get dangerous, because if you stop breathing, then obviously you're going to die. So let's compare 3 different drugs. We have the full agonist methadone, we have a partial agonist called buprenorphine, and then we have the antagonist called naloxone or Narcan. Some of you may have heard of that drug. I could use any full agonist here. I could use morphine or fentanyl or anything like that. So if you notice here that if I have a full agonist on board, you're going to see very high opioid effects because it's directly activating those receptors. It's working great, right? With a partial agonist, what do you notice here? Well, even if I'm getting the same receptor occupancy as I would with a full agonist, notice the effect is very limited because this is only partially activating those receptors. This is really good for patients who are, say, for instance, have an opioid use addiction, and we're trying to get them off of that. We can actually give them a partial agonist such that they only get minimal effects here, but they also don't go into withdrawals and things like that. So we'll talk much more about that when we get into the opioids. The really important thing that I want you to know is the antagonist. What happens when I introduce an antagonist to combat the effects of the full agonist? Well, if you notice here, the effects are 0, right? Because now all of those receptor sites, those opioid receptor sites that methadone would normally be binding to, have now been occupied by naloxone. Now, there's no effect whatsoever. So what does that mean for your patient? Say someone overdoses and they take a whole bunch of methadone. They stop breathing. They are respiratory depressed or CNS depressed. Now we give them the antagonist naloxone. I don't know what any of your backgrounds are currently, but some of you may have worked in ER before and seen someone get Narcan. It's pretty dramatic when you see it because all of a sudden all those receptors will get rid of all that methadone. And now they're occupied by Narcan. The patient wakes up like that. And frequently they're vomiting and they're very cranky and all of that, but it works very well because now they have this competitive antagonist on board. Okay, so just to give an example of what that looks like clinically between the use of full, partial agonist and then an antagonist. Yeah. So we talk about specificity of a drug. We're talking about basically how good it is at binding to its receptor site and only its receptor site. We're going to see, though, that drugs can have a wide range of actions depending on how specific it is. And so things that are high specificity, they only work on one type of receptor typically. They're very specific in what type of tissues or what type of cells they're going to affect. And hopefully, because they're very specific in how they're working, it's going to have very limited toxicity, limited adverse effects on the body, right? So a good example of this would be antibiotics, right? So we're talking about things that treat and kill bacteria. They're very specific for killing bacteria. They're not very good at killing our cells, which is a good thing because we don't want our cells to die off. We just want those bacteria to go away for your ear infection or your sepsis or whatever the case may be, right? On the flip side, if you have low specificity items here, you're going to find that they can affect many different types of receptors. They can affect different types of tissues here. They're just not really specific. And that typically means we're going to get more adverse effects, right? So for instance, chemotherapy drugs are things we use to treat cancer. Unfortunately, a lot of your chemo drugs don't know the difference between a cancerous cell and a non-cancerous cell, which means it's going to be affecting them equally, which is why people who receive chemotherapy, you see things like infection because it kills off their white blood cells. You can see things like alopecia because it kills off those hair follicles. All those sorts of things are related to the fact that these drugs have low specificity and you just can't tell the difference between cancerous versus normal healthy cells, right? Other things like certain older antidepressants, they weren't very specific, so they caused all kinds of side effects and made them really dangerous when people overdosed on them, versus some of the newer agents that we have, like our SSRIs and things like that, are much safer because they are more specific. So in general, high specificity is a desirable thing. May not always be possible with our given drugs we have available, but it's what we prefer to do. Okay. So another term I'm going to get into briefly here is what we call stereochemistry. And so I don't want to scare anyone away with, if they're having flashbacks to chemistry or anything like that. But most drugs you're going to find usually come as what we call a racemic mixture. And so basically what that means is a lot of molecules will have what we call right-handed and left-handed versions of one another. They are chemically identical, but they're mirror images of one another. So if you imagine your left hand and your right hand, they look identical, but if you were to try to overlap them on one another, you notice your thumbs are on the wrong side, right? So they're mirror images of one another. Why do we care about that? Well, we care about that because you may find that with a racemic mixture of a drug, given that it's both left and right-handed versions of that molecule, that leads to good positive therapeutic effects, but may also have some toxic effects in there. And for some drugs, we can separate them out and realize that maybe the left-handed version is where all the therapeutic effects are. The right-handed version is where all of the toxic effects are, right, for instance. So by separating those out, you also are able to maybe help and use only the therapeutic version of that one, right? And so when I talk about a racemic mixture, that means an equal proportion of left and right-handed versions of the molecule. You'll sometimes see R or S, or you may see dextro and levo, for instance. It's just denoting you have just a single enantiomer. One of those enantiomers is either the left or the right-hand version, right? So just to give you an example, some of these here, albuterol, which you mentioned as a beta-2 agonist, is a racemic mixture, right? It's dextroalbuterol and levalbuterol. Well, if I separate that out and just get the levalbuterol, some people feel has a more favorable side effect profile. Now I have a new drug called Xopenex, right? One of the important things to realize, though, is that the conversion of doses here between the two, right? So if I have a racemic mixture, which is 50% left and 50% right, if I were to separate that out, half of that is going to be left and half of that's going to be right. So for instance, 5 milligrams of the racemic mixture albuterol, 5 milligrams, 2.5 of that's going to be the left-handed, 2.5 is going to be the right-handed. Or to separate that out, levalbuterol, an equivalent dose is 2.5 milligrams, right? So you see how that's an equivalent dose here. Or the antidepressant drug citalopram is a racemic mixture. 20 milligrams of that is equal to 10 milligrams of escitalopram. We do this a lot when we are trying to convert patients over from one drug to another, and we need to make sure that we're getting equivalent doses. And so that's why it's important to kind of understand the difference between a racemic drug versus the actual enantiomer, the left or the right-handed form. The other benefit too is it actually gets a new patent, and we'll talk about drug patents in a little bit, which means that the drug companies can now sell a new brand name drug and they can make a bunch of money off of that. So I'll mention that in just a few minutes. Here's an example of a drug called Zyzal, which is actually, I'm sure some of you heard of the drug Zyrtec before, which is cetirizine. Here's an example of one where they separated it out and they say, okay, well, this is just the active enantiomer. This is just going to be the levocetirizine, right? So there's active enantiomer of Zyrtec with no dextrocetirizine. I really like this ad because it says wisely designed to be different. But then they say right at the bottom here, the clinical relevance regarding the absence of dextrocetirizine is unknown. Okay, so yes, you wisely designed it to be different, so you get a new patent and you make a bunch of money, but we don't know if actually doing that did any good. It's a little strange. So that's another one that where you're going to see that sometimes there's a little bit of cynicism here, and money does drive quite a bit of this stuff. So we'll talk more about that a little bit later on. See, Vlad said that thalidomide is another famous drug for its enantiomers. Yeah, we'll talk about thalidomide a little bit later on. We start talking about teratogens and whatnot. So it's good. I'm glad you brought that up. So anyway, so getting into some more definitions here. So downregulation is basically where the normal cell receptor degradation is basically exceeding synthesis. What does that mean? Is it basically you're having a fewer total number of receptors available for drugs to interact with. Okay, so if I had 10 receptors available, now I'm down to 5. Okay, what does that mean? Well, basically it means that the responsiveness to that drug is diminished, right? If I only have 5 receptors to interact with, rather than 10, I'm only going to get roughly half that effect. Fewer receptors means fewer things for the drugs to bind to, means less effect overall. And so you have to do things like increasing the dose to overcome this in some cases, right? Very rarely are you giving doses of drugs to occupy 100% of your receptors. Usually you'd be giving such a big dose, you'd be probably killing the patient. So in order to overcome that, sometimes we have to increase the dose, right? So this is why sometimes you'll see tolerance to medications over time where patients are like, yeah, that dose used to work really well for me, but then I had to bump it up to get the same effects. A lot of that has to do with downregulation, especially with agonist drugs, right? Because the body likes homeostasis. So if I'm constantly activating a receptor, the cells are going to say, whoa, this is too much activation. Let's drop this down a little bit. And they'll do that by downregulating those receptors there, okay? The opposite will be seen with antagonists. You actually have an upregulation with that one. So for instance, if I'm taking something called a beta blocker and then blocking beta adrenergic receptors, right? The cells are going to say, well, we're not getting enough activation here. Let's go ahead and provide more receptors. So now you're more sensitive to the effects of agonists that would then bind to that receptor there, right? Clinically, this does come up and can be important in some cases there, which I'll mention a little bit later on. Some other definitions we'll talk about here include bioavailability. This is basically the amount or the percentage of a drug that gets absorbed through a given route. We're going to talk much more about routes in just a little bit, but this can vary greatly. So for instance, if I were to give you a drug and I start an IV and I just push the drug directly into your veins, well, 100% of that is now in your system. So that's 100% bioavailable. Typically, IV is always going to have the greatest bioavailability. But the oral route, though, is where it gets a little bit more tricky, right? And most medications are given orally. And so you can find that depending on things like stomach acid production, things like enzymes within the GI tract, you may find that it actually diminishes how bioavailable a drug will be. In some cases, you can't give a drug orally because it just gets metabolized. So for instance, insulin, we don't give oral insulin because it's a protein. It gets degraded in the stomach acid. That has 0% bioavailability. Other drugs get absorbed great and it has 100%. It can go anywhere in between here, right? Another really important term here, though, is what we call first pass effect. And the first pass effect basically means that when things get absorbed from the GI tract, the first place it's going to hit basically is the liver. And the liver metabolizes the majority of drugs that are out there. And some degree of it's going to get metabolized prior to it entering that systemic circulation, right? Basically, this is what I call the liver tax. So for some drugs, this will be quite extensive, such that you get 0% of that drug making it past the liver. It's going to just metabolize it all, making the oral route not really viable. For some drugs, it's not going to get metabolized at all through the liver, and it's just going to pass straight through, right? So this is called first pass effect, and this is important because there are ways that we can actually change that and either make a drug more or less effective by what gets through the liver, essentially. And then in some cases, we have what we call prodrugs. And so this is basically drugs that have made it to the big leagues. There used to be amateur drugs. I'm just kidding. Prodrugs are drugs that are inactive in their natural state, but they are then activated usually through metabolism in the liver. So a good example of this is the drug called Vyvanse or lisdexamfetamine. This is actually a drug used for ADHD. It's quite popular. It by itself is not a very good drug because it just doesn't activate the right receptors like it needs to. However, once it gets passed through the liver after you take an oral dose, it then gets converted there to dextroamphetamine, which is the active form of it. So that's when we say a prodrug. Basically means inactive, but it has to be activated usually through the liver. We'll talk a lot more about that when we get into the kinetics section later on. Another important term we'll talk about when it comes to kinetics is called volume of distribution. A lysine group gets reviews. There you go. Yeah. So looking at this with the volume distribution, basically this means is like where does the drug actually get distributed throughout the body? And you're going to find that once drugs get into the central circulation, once they're in the blood supply, you're going to find that it just doesn't stay there. It'll then get distributed to some degree to the tissues. And we'll talk a lot about this, but a lot of it has to do with lipophilicity of the drug and tissue binding and things like that. And we'll say, okay, does the drug like to get partitioned really far out into the tissues, or does it like to stay in the bloodstream? And so that'll be important when we get to the kinetic section later on. But this is an important concept. So if you think about patients who use marijuana chronically, for instance, marijuana is a really lipophilic substance, the THC specifically, and so it likes to distribute really far out into the fat tissue. And so that's why you can have patients, when you're talking about them passing drug tests, they can be positive for THC for months in some cases if they're really high chronic users, because they have such tissue burden. They have so much THC built up in the tissues because of the high volume of distribution. But we'll talk a lot more about that in a different section. So now what I want to talk about is going to be our routes of administration. So different ways we can get drugs into the body. How is that going to occur? And so this is a good table to refer back to. I think, knowing the specific percentages here, not so important for my purposes. I want you to have a general idea, though, about these sort of things. So, for instance, if I'm talking about intravenous drug administration, it's going to be 100% bioavailable because it's going right into the vein, right? The other important thing, though, I want you to take away is going to be some of these characteristics here in terms of like onset of action, some of the drawbacks of some of these different routes of administration, and things like first pass effect. So we'll talk about these as we get into them individually. So first off, IV, right? Most people have heard about getting an IV placed, pushing drugs IV, etc. This is basically where there is a catheter placed inside of a vein in which you can then push fluids, you can push blood, you can push drugs into, right? And so basically the benefits of this is that you get very fast onset of action, usually seconds to minutes, and very titratable, right? Depending on how fast I'm giving a drug, or if I'm giving a continuous infusion, I can titrate that to get basically the effect that I'm looking for. Again, the bioavailability is 100%. Everything that I push into that vein is in the system right away. And so this can either be given as what we call intermittent doses, so you get like a bolus dose. So say, for instance, you get an antibiotic every 6 hours. That would be an intermittent dosing sort of schedule there. Or you can get continuous infusion. So say if you ever hear like someone getting an epi drip or a dopamine drip, that basically means it's a continuous infusion. And I can actually titrate that dose up and down to get to the effect that I'm looking for, whether it be a certain blood pressure or a certain sedation level or whatever the case may be. Okay. Another important concept, though, to consider too is central versus peripheral administration. When I say peripheral administration, I basically mean that the drug is getting dumped out into a peripheral site, usually the arm, could be other sites as well, right? That's a peripheral administration, and usually the veins you're dealing with there are smaller. The flow of blood in the venous system is going to be slower, such that it may not be reasonable for some drugs, because some drugs can be really irritating. There's also the risk you could do something called extravasation or extravasation, where basically the catheter or something is going to break through that vein and then dump drug into the surrounding tissues. That can be pretty bad in some cases here. So for instance, here's an example of an anti-epileptic drug or an anti-seizure drug called phenytoin that actually extravasated into this person's hand and causing what we call purple glove syndrome, basically severe tissue necrosis. In some cases, that has led to amputations before, so not great from that standpoint. What we can do instead is use what we call central administration of drugs. Usually a catheter is placed either like through a subclavian line or through a femoral line, something like that. And basically it's a catheter that goes all the way up through the inferior vena cava and then dumps out basically directly into the right side of the heart. And so the benefit of that is it's much higher flow. There's a lot of blood there. It dilutes out the drug quite quickly. So if you ever hear like a central line, that's what we're talking about. It can give higher concentrations of a drug. I can give faster. I can give drugs faster in some cases. It can be beneficial, but it's more labor intensive. It's a lot more difficult to get a central line than a simple peripheral line. And each of them has their own uses depending on the drug that we're giving there. What are the disadvantages, though? I mentioned the extravasation. Also, you can't take back what you gave. So once that dose is in the system, it's there, right? So you basically have to wait for the drug to be metabolized and eliminated. once you've done that. So unfortunately, you want to be really sure when you give a drug that that's appropriate and what your patient needs. You also have to worry about things like the actual physiochemical instability of some of these things, or interactions with one another. So you can actually precipitate out substances which can, one, lose the line if you have a bunch of crystals forming in there and blocks it up, or it could happen in your patient too. And there's been cases of say like pulmonary embolism that have been started by a drug precipitating out potentially, right? Kidney damage, all kinds of other things. So basically, those are some of the disadvantages, but very common use. We give things IV all the time. There's also another way we could do it. So what if you have a patient who is a particularly difficult stick? It's very difficult to get an IV started for them. This would be in the case of patients who are maybe dehydrated, older patients, pediatric patients. Well, sometimes you got to still get drugs into them some way. And so this is where we can use something called intraosseous administration. So this is where basically you can take this little power drill here and insert a needle into the bone marrow itself. Now, there's many sites you can use. The tibia is probably the most common one that I've seen, but this is really handy and useful in emergency situations where you need to get a line placed quickly without a whole lot of fuss trying to find an IV or trying to find a vein. And so I see this a lot in pediatric emergencies and things like that. And basically, you can push fluids through here, you can push drugs. It's basically a big non-compressible vein, and everything gets absorbed just like it would through an IV. So very handy alternative to getting an IV placed. Other routes of administration include sub-Q. We're going to find that this is nice from a patient administration standpoint, so it's relatively easy for patients to be educated on how to administer their own drugs from a sub-Q standpoint. Usually the abdomen is being used most commonly for that, but some other cases for use include things like implants that can be placed, so certain forms of birth control can be placed underneath the skin to slowly release hormones over the course of many months or years. As I mentioned, with the self-administration, insulin is probably the most common thing you'll see patients injecting themselves with, and you get pretty good bioavailability. It may not be 100%, but it's fairly good because things have to be slowly absorbed through the sub-Q fat, through the muscle, into the circulation itself. It will have a slower onset than IV and intramuscular administration. So if it's something you don't need really fast action on, like a dose of insulin, that's perfectly reasonable to use a sub-Q route there. The big disadvantages, though, is that one, patients typically don't like injecting themselves. It can cause pain. You can see necrosis in some cases. Here's some ecchymosis happening here from injection of a sub-Q anticoagulant, something like a Lovenox or something. And skin infection could also be a risk as well. So those are some things you want to watch out for in terms of the disadvantages of sub-Q administration. There's intramuscular administration. This is just what it means. We basically will put a needle down into the muscle and then inject the medication there. The benefit of it is that it's faster than sub-Q administration, has high bioavailability. Downside, though, it's pretty painful. Patients don't particularly like IM injections. And you're also limited by volume in a lot of cases. And so larger volumes you're giving equals more pain, and so that means that drugs need to be more concentrated in order to be given in a smaller volume. It means we may not be able to give a full dose of a drug in just one shot, unfortunately. Typically, we try to limit this to no more than 3 mLs. And if you think about 3 mLs, that's really not a lot of volume there, right? You're also going to find that it requires patients to have good blood flow to that muscle to be absorbed well. So if you have someone who's hypotensive, they're not going to be perfusing the muscles all that too well. They may not absorb that drug as quickly or as fully as you would see with someone who had a normal blood pressure. You can find some other issues too, things like obesity or basically any extreme of weight could have issues altering the absorption too, and then things like heat and exercise can affect it as well. So a little bit of caveats there to note, but again, another common route of administration. Most frequently, you're going to use things like the gluteus maximus, the deltoid, or the vastus lateralis. Probably more common IM administration you might think of includes things like an EpiPen is an IM shot. It's probably the most common thing I think of when I think, and then a lot of vaccines and whatnot typically are given intramuscularly. You can even give things intrathecally. So this is a really very specific way of administering things directly into the spinal column to avoid having to cross the blood-brain barrier. And also make sure that you're just working there directly in the spinal column and not anywhere else. And so we can basically do this with several things like chemotherapeutics, so things for cancer, antibiotics in some cases. But the most common place you might see this would be used for labor and delivery, right? So if you ever hear like an epidural being placed for a pregnant woman who is giving birth, this is where they're doing it, right? It's basically an epidural administration of the medication, and it's nice because it doesn't affect the whole patient. It just affects basically wherever it's sitting at in the spinal column. So, obviously a pregnant woman giving birth, they probably need to be numb roughly from, the stomach down, versus they don't need the whole body to be affected. And so intrathecal administration, epidural administration can be very useful for that. You can't see spinal headaches. That's probably one of the more common side effects you're going to see with that in terms of drawback. So this needs to be done really under good sterile conditions. It is more labor intensive. You have to have special training to do so, but can be effective where it is indicated. So getting into some of the more close to oral routes of administration, we have sublingual. This is basically going to be things where you would place a tablet, say, underneath the tongue. This is good for things that you want to bypass that liver tax, and if you want to bypass first pass effect, this is a good way to do that. Basically, the drug will just be absorbed from the oral mucosa and will basically skip the liver for the most part, and so you get better bioavailability, doesn't interact with the liver. However, many drugs are not able to be absorbed from the mouth, so you will find that this is used relatively sparingly, only for drugs where they actually can be absorbed. The most common one you're going to see for this would either be things like Tylenol, or dissolving tablets, or you may see like Zofran or ondansetron. Zofran is like given like water in most ERs, because anyone who is nauseous or vomiting, they're going to get a dose of Zofran. If you think about it, if you're vomiting, you probably don't want to swallow a tablet, and so using something sublingually is going to be pretty beneficial there. So if you ever see ODT, that just means orally disintegrating tablet. Some disadvantages is that very few drugs can be used sublingually. So if you see it, it's because that drug is specifically suited for it, but not many are. And so that then gets us into the oral route of administration. This is by far the most common, quite safe, most economical. It's very easy for patients to take the drug themselves fairly easily. Some disadvantages, though, include things like patient compliance, right? So if you imagine a small child, they're probably not going to be able to take a large tablet, right? They're probably going to need liquid medications. If you imagine someone with, say, for instance, progressive Parkinson's disease, they have dysphagia, they may not be able to swallow capsules or tablets, right? And then you also have to think about first pass effect as well. So some drugs are not going to be viable via the oral route because of the fact they can have extensive first pass effect and not really get much into the circulation there, right? The other big thing you have to think about too are going to be food-drug interactions. And so this is where timing of medications can be really important. This becomes more of an issue with older patients in particular. So for instance, if they were taking something like the fluoroquinolones, so this is an antibiotic group, includes things like Cipro and Levaquin. If you think about someone, say you have an older patient with a UTI, right? Urinary tract infection, they're taking Cipro for that. Well, older patients too, they have to worry about things like osteoporosis. So what do you tell them to drink? You tell them to drink a bunch of milk so they can get their calcium in. Well, calcium from that milk would then bind directly to the fluoroquinolones and basically prevent it from being absorbed systemically. So that UTI now doesn't get treated because none of that fluoroquinolone is making it into the system, essentially. So there's some downsides of that. We'll talk more about those in their specific cases later on. There's different dosage forms that we can use. So for instance, we can do things like enteric coating, which will actually coat the drug with a coating that is resistant to the low pH of the stomach. And then once it gets in the small intestine where pH rises, you then find that it's going to go ahead and be absorbed quite easily there. The coating will melt away and allow for the drug to be absorbed. This is good for drugs that are not stable in the stomach acid, for instance. Other things we could do would include controlled release preparations. These are good for allowing drugs to be absorbed slowly throughout a 12 or 24-hour period here. And you'll see lots of different names for that, including things like sustained release, extended release, etc. This is handy because maybe instead of taking a drug 3 times a day, they only take it 1 time a day. Or if you think about a lot of your ADHD medications, they are typically going to be extended release preparations, because if you can just give 1 capsule to a kid in the morning and they don't have to take any drug with them to school, for instance, assuming kids ever get to go back to school, they don't have to carry a controlled substance on them. They don't have to worry about the nurse giving it to them, any of that. They just take it in the morning and they're done, right? So you'll see that used somewhat commonly. There's the rectal route of administration too. This one can be a pain in the behind, if you might imagine. Just kidding. Some advantages here is that it's good for patients who can't take PO medications. So if you think about infants, are a good group here, or older patients. You also bypass a lot of first pass effect here, right? So you're going to find that the rectum is very highly vascularized. It's going to be very thin membrane, so it gets absorbed. Drugs get absorbed quite easily, and it bypasses that first pass effect. So disadvantages to this is going to be maybe in some cases you can have incomplete absorption, especially if the patient expels something like suppository too early. You're going to find that, while infants might not have a problem with suppository, if you try to give this to a teenager, they're probably not going to be so compliant with that. So that can be an issue. If you notice here, basically a lot of these suppositories will come in a cocoa butter sort of base here, and then as it gets into body temperature, 98.6 degrees, it will then start to melt, and that will allow for the drug to be absorbed more fully. Please make sure to tell patients though to take this foil wrapping off where they try to insert it. I've seen a few cases where they did not do that and things did not go well for their rectum. So other routes of administration include inhalation, and so this is good for drugs that work in the lungs because essentially we can get drugs directly to the site of action where they're needed, and that can help to limit systemic side effects and help to limit how much effects you're going to see throughout the rest of the body. So also they get really fast absorption for things that do get absorbed well. So for instance, like crack cocaine, which is inhaled, smoked, has a very fast onset because the lungs have a high amount of surface area, highly vascularized. Things get absorbed really quickly there, for instance. I don't suggest you take crack cocaine or give it to your patients, but just to give you that example. Some disadvantages, though, is that if patients are not doing things, if they're not inhaling these appropriately, they're not going to get very much drug down into the lungs. Most of it is either going to be expelled through expired air, or it's going to end up in their stomach. So technique is really important here. This lady has bad technique. You should not use your inhaler like that, just for example. And there are different ways to give this. So for instance, there's things like meter dose inhalers, which are basically she's holding a meter dose inhaler where there's a propellant that will expel the drug out when pressed down. There are dry powder inhalers where patients will basically inhale a drug that's a dry powder and they'll kind of perform that inspiratory force needed to get the drug aerosolized. Or you could use a nebulizer, right? Basically you will put a liquid medication into a nebulizer cup that will sort of vibrate at very high frequency that will allow it to be aerosolized and they can breathe that in. A lot of different ways. We'll talk more about that probably when we get into the asthma section later on. Here's a funny thing. I think this is really important. So when you're teaching patients how to use different devices or different techniques, it's good to use the teach back method, where basically you explain it to them and you say, hey, can you tell me how you're going to take your medication? And so this is a good way to diagnose if patients have compliance issues here. And that may seem silly, but I can guarantee you someone has done this before in the past. That's probably why I got written into the show. So, patients will do all kinds of crazy things, especially if they are lay people. They don't have a lot of medical background or knowledge. So it's really important to make sure they understand what they're supposed to be doing in those cases. Anyway, up next we have the transdermal route of administration. TD is typically how that's going to be abbreviated. This is going to be good for medications that may not be bioavailable from an oral route, and you may not have access to sub-Q or IV administration. They also allow for nice slow release of drug over the course of several days in some cases here. So also it's nice from a compliance standpoint. You just slap a patch on, you just don't think about it for the next couple of days. And depending on the drug, it could be 1 day, 3 days, 7 days in some cases there. So you'll notice here that basically the drug has this nice large reservoir of drug, and it will then slowly release throughout the skin into the systemic circulation through the process of passive diffusion, which we will talk about later on. Now, some disadvantages here are that not all drugs can penetrate the skin. So if it can't get past the skin, then you're not going to find that it can get into the systemic circulation. It's no good that way, right? It also doesn't work on open wounds, or actually works too well. You may find you're going to get way too much absorption, which can be a problem. And then not only that, but when patients take off the patch and throw it away, that can be a risk for poisoning. There's still a lot of drug left over in a used patch here because it does work on this process of diffusion. You can find that can be a risk for poisoning for animals, for young children. I'll never forget, I had one patient who came in. It was a 10-month-old. It was being brought in for lethargy, and low heart rate, low blood pressure. Couldn't really figure out what was going on with the kid. And I remember talking to the family and I said, hey, is anyone taking any kind of blood pressure medication? And the dad said, oh yeah, well, I take this clonidine patch, and clonidine's an antihypertensive drug that looked like what this kid could have gotten into. And I was like, well, is there any chance the kid could have gotten into one of these patches? And he's like, no, he's not even getting around that much. No way he would have gotten it. I said, okay, well, are there any siblings in the house? And he said, yeah, he's got a 2-year-old brother. And I said, okay, let's see what went on here. And so I said, well, perhaps when you threw one of these patches away, the kid thought patches are good, make people feel better. So he grabbed one of those, fed it to little brother, and then now here's where we're at. The dad's like, there's no way that's not possible. No way that's going to happen. Sure enough, 3 days later, the kid ended up pooping out a patch. So again, things can happen. Risks for poisonings are certainly possible. As I mentioned, I'm a toxicologist. My kid ate a bobby pin. So I might show you guys some pictures of that later on. Anyway, there are other routes as well. We can give things ocularly in the ear via various mucous membranes. We will talk about those more specifically as we get into individual sections. So, if we were talking about, for instance, ENT drugs, we'll talk about ocular administration and things like that. So just keep that in the back of your mind. We'll get into it next semester. So briefly, I want to talk about drug development. How does a drug actually get out to where it's available for patients? So basically, this is all overseen by the Food and Drug Administration, and their goal is to make sure that medical devices and drugs and cosmetics and anything like that that is getting out for lay people use is going to be safe and is going to be effective. And there's been many laws that have come about to try to make sure that this happens. Many disasters, unfortunately, happen where people have been injured by drugs that were not safe or contaminated. And so this is what has led to the current system that we have available to us. And so basically, you're going to find that, say, a drug company wants to bring a new drug to market. There's going to be many phases they have to go through in order to get out to that market, right? So just to kind of walk you through it briefly. Let's say a drug compound they're working on, they're going to kind of go through many thousands of different molecules to try to find one they think is going to be effective for depression or blood pressure, whatever the case may be here, right? And so eventually they're going to start using it on animal testing to try to figure out, is it going to be safe or effective, right? So, and again, animal testing is not one-to-one with humans, obviously, although some of your patients may act like animals. My children do often, but this is useful for trying to figure out, how does the drug work, what's its mechanism, what's the kinetics, etc., right? At that point, once the drug company says, hey, we want to bring this drug to market, we want to start entering it into human trials, they go to the FDA and they get what they call an IND, or an investigational new drug application. And basically, this gives the company 20 years in order to make money on that drug, okay? And so basically, the clock starts ticking as soon as they go to the FDA and they get that initial IND. And that's important because drugs can only make money if they're being sold. So it's in the financial interest of the drug company to get through these phases as quickly as possible. And there might be some money changing hands here or there. I don't know. Don't let my cynicism bother you too much. But anyway, so now we start the clinical testing phase. And so there's different phases here, phase 1, 2, and 3 trials that occur in the clinical testing phase. Basically, phase 1 is going to be done in a small number of patients, maybe talking about tens of patients getting the drug. And they're typically for patients who are healthy. They don't have the disease state in question. So for instance, if it's a new antihypertensive, it's going to be people that don't have hypertension. And we're just trying to figure out, is the drug safe? What are the side effects? What are the kinetics of the drugs? Okay. Once that has passed that phase, then phase 2 starts. Now we're starting to get into maybe dozens of patients, maybe 100 patients. Does it actually work in patients with the disease state? Is it actually lower blood pressure? Is it safe and effective? And then finally, we're going to get into phase 3 trials. We're going to get into maybe hundreds or thousands of patients and to figure out, okay, does this work, say, compared to placebo? Does it work compared to the gold standard treatment, etc.? And once they have enough evidence to say, yes, we think this is effective and safe, we want to bring it out to the market. Now, after about 8 or 9 years or so, the drug will then come out into the market. Okay, and then starts what we call the post-marketing surveillance, or the phase 4 trial. And so this is where basically the drug is being sold on the market. And guess what? If you've ever taken a drug product ever in your life, you were part of a phase 4 trial. This is part of the ongoing monitoring that we do to make sure the drugs are safe. And if you think about it, a drug that has a 1 in a million side effect to kill somebody, well, you're not going to find that unless you give it to millions of patients. And that really doesn't happen until you get to the phase 4 of this. And so at this point here, this is where we do a lot of surveillance, we do a lot of monitoring. If side effects do start to occur that were not noted before, those will then get reported. And some drugs get taken off the market at this point because they were showing to kill people, or they're ineffective, or whatever the case may be. But basically, over this time period, whenever they come out, if it takes them 15 years to come out to market, then they only have 5 years to recoup that expense. Because after that 20 years expires, once they file that application, you have 20 years. Once it expires, then generics become available. Then you can have others come along, and instead of just selling Motrin, now I can sell generic equate ibuprofen, for instance, right? So that's really the financial incentive for them to get this out quickly, so they have more years to sell it as a generic or as a brand name drug. Another term we'll talk about is called bioequivalence. This is basically when you're talking about generic drugs, how they have to show that they're just as safe and effective as the brand name drugs. They have to basically show it's the same strength, the same concentration, same route, everything. This is why when you go to a pharmacy, if you were to get, say you were to write for a brand name drug, if a generic is available, we as pharmacists will sub that out and give the generic because it's a cost benefit to the patient. And it's going to be just as effective because they have shown what we call bioequivalence. So if someone's like, man, the brand name just works better for me, typically it's more of a psychosomatic sort of a thing, more of a placebo effect, as it were. But for the most part, generics work just as good as the brand names. And so here's an example of doing like a bioequivalence study, trying to show that a generic is working just the same as a brand, usually within a certain percentage, that show they get the same blood levels of that drug in a particular patient. Here's an example of a antidepressant called bupropion between the brand and the generic version of it. So anyway, so the last thing I think I want to talk about here is going to be receptor signaling. This will be the last section for part 1. Basically, as we mentioned, receptors are anything that the drug will bind to and then either activate or not activate, but at least is some sort of physiologic change that occurs within that cell or that organism. And so looking at communication between these cells is typically through signaling molecules and activating receptors, right? So basically you're going to find that signaling molecules are quite diverse. They could be antibodies, they could be hormones, they could be neurotransmitters, they could be literally anything. They're transmitted via several different ways. Now, some of this may be kind of basic to you, may be like kind of a rehashing a little bit of your biology, but I think it's important to understand this, how things normally get signaled, to understand how drugs can interact with the system, right? If you don't understand how things work normally, it's harder to understand how the drugs are going to be interacting and causing these changes here. So basically that receptor is anything that the signaling molecule binds to. The effector is going to be basically that mechanism that is activated by that receptor. So for instance, if I have insulin bind to a receptor and I cause lower blood sugar, that's kind of the effector mechanism. And then we'll also talk next time more about what we call second messengers. These are basically kind of intracellular signaling molecules that are used to cause physiologic change, right? The drug itself, or the extracellular signal, that ligand, that's the first messenger. But we'll talk more about those a little bit later on. Now, there are different ways that cells can contact and talk to one another. Here's an example of contact-dependent cell signaling, where they can basically just via touch be able to talk to each other. So the signaling molecules on the surface of the cell is talking to that then target cell's receptor, right? This is handy for things like trying to prevent cells from overgrowing. So for instance, with like cancer, they lose the ability to talk to one another and they start just kind of growing sort of ad infinitum as a result of loss of cell contact dependent signaling and things like that. That's one way. It's not as common as we'll see with certain drug signaling molecules. There's one called paracrine, where basically a signaling cell will then release neurotransmitters or release some sort of signaling molecule, and it will then target sort of nearby cells, right? So sort of a short distance bit of communication there. We then have synaptic signaling. This is really important when we get into the psych drugs, when we talk about things like antidepressants and anxiety and epilepsy, and we talk about all kinds of neuro stuff and psych stuff. This is where the synapse is going to be coming into play here. And so we're going to see here that basically one cell is going to be, a nerve is going to be sending the signal through an axon that will then release neurotransmitters onto the synapse here, right? And then cause some downstream effect to occur. There's going to be a lot of ways drugs can interact with this to either increase or decrease the amount of signaling molecules being released here and affecting those downstream cells. So keep this in mind. This will be really important for things like, Parkinson's and Alzheimer's, all kinds of different neuro conditions. And then kind of one of the more important ones too we talk about is going to be the endocrine signaling, where basically these cells are going to be releasing a hormone or some sort of signal molecule into the bloodstream, and that can then target any other cell throughout the body, which is why these are really powerful signaling molecules. If you imagine something like insulin can affect many different tissues throughout the body, not just the liver, can affect the muscles, can affect adipose tissue. Think about cortisol being released from your adrenal glands, right? Think about that. I mean, you probably have a lot of cortisol, and that you just started PA school, right? It's going to be affecting almost every single tissue type that's out there because it's working through this endocrine sort of system here. This is really important too. We're going to talk a lot about this. We get into like diabetes and thyroid conditions, all kinds of stuff. So again, these are the synaptic and the endocrine signaling we're going to talk a lot about in terms of drugs. Now, in terms of like receptor, we talked a lot about receptors so far, but what other things can sort of act as receptors? Well, it can be really anything. Anything the drug binds to and causes some physiologic change can be a receptor. So for instance, we can look at enzymes. Enzymes can be a receptor site. So for example here, you have a drug called methotrexate. Methotrexate is a really important drug. We use a lot for rheumatologic conditions. We use it for cancer. And so basically what it does, it actually inhibits this particular enzyme, dihydrofolate reductase. Now again, am I going to ask you on the test, what's the mechanism of action of methotrexate? Not for this class, but in the future, yeah, who will? But just to give you the example to see, okay, well, here's how these different drugs can affect different types of receptors. Basically, by affecting this enzyme and by preventing it from working, our cells can't utilize folic acid very well, and that can inhibit DNA replication and thus inhibit cell replication, right? So the enzyme is ultimately what the target is going to be, what the receptor is going to be for this particular drug. We have transport proteins being affected as well. So for instance, when we talk about cardiac function, we're going to find that the flow of electrolytes is extremely important to keep well regulated. Otherwise, you're going to have an arrhythmia and you're going to die. And so there's a lot of different protein channels that are going to be affected here. So for instance, we have the ATP, the sodium potassium ATPase pump. Probably heard of this pump before. This is really important for neurologic function. This is really important for cardiac function. And we can have drugs that can affect this specifically. So for instance, we have digoxin, which is a drug we use for congestive heart failure. And this is actually able to affect this particular transporter specifically, actually inhibits it. And by affecting that transporter, this is the receptor here, you're going to be able to change things like the flow of sodium and calcium within the cell, and that can cause the contractility or the squeeze of the heart to actually increase and can help out with that heart failure. Again, just another example of a type of receptor, in this case, a transport protein. You can have structural proteins being affected. Here is an example of a drug called colchicine that we use for the condition gout, right? Gout is going to be, in this case, we have uric acid crystals that are depositing in the joints. And basically, by colchicine working to affect the mitotic spindles and affecting tubulin, it's able to disrupt the ability for certain cells to migrate to that site of where the gout is to cause inflammation. So this is actually where it's affecting structural proteins within the cell itself to affect things like cell locomotion and its ability to get around in the body. And so there's 4 main types of drug receptors we're going to run into. There's going to be ion channel receptors, G protein coupled receptors, enzyme linked, and then intracellular receptors. And so I'm not going to get too in the weeds on these, but I just want to illustrate the kind of common ones we're going to run into and how they're going to be affected here. Basically, when I say the first 3 that we talked about, so like the enzyme linked, the G protein, and the ion channel, these are all going to be cell surface receptors. These are all going to be things that are affecting the drug, or the molecule is going to be affecting the cell surface, right? And then some downstream changes are going to occur within the cell. Versus the cytosolic or nuclear receptors, this is where the drug gets into the cell itself and then can actually interact with the nucleus and change things like gene transcription and protein production. And so you can see here how these 3 are going to be basically work on the cell surface. So the ion channel linked receptors are really important because when these are activated, these will allow for ions to flow in a certain direction. Usually this is going to be along their concentration gradient. And this has really big impacts on things like cardiac function, on your cell, like your nerve function and things like that. And also, a lot of things like neurotransmitters play a role here. So, for instance, like glutamate and GABA and all of that can affect these channels here. And so, for instance, if I have GABA come and affect a certain type of ion channel, it will then open it up and allow things like chloride ions to flow into the cell and cause some downstream change. So, if I'm having a seizure and I have GABA come along and open up the channels, chloride flows in and then can stop the seizure, right? This is an example of how those physiologic changes can occur based off of this. And again, it's not just chloride, it could be potassium, sodium, lots of different things can happen here. But basically, once it's activated, the signal molecule hits here, it's going to open this up and allow ions to flow in a certain direction. And so just to give you some other examples, things like nicotine is responsible for activating the nicotinic acetylcholine channel. It makes sense, nicotinic receptors. That causes, sodium to flow into cells in the CNS and causes activation of those cells, right? Things like calcium channel. If we can block calcium channels, we can affect muscles like the smooth muscle around the vasculature. They can lower blood pressure. Lots of different examples here. Again, don't memorize these specific ones. I'm not going to ask them on the test necessarily, but just be aware that ion channels are allowing ions to flow through in a certain direction, and that causes sort of downstream physiologic changes to occur. We're going to get into all those examples and specifics when we get into Pharm 1 and Pharm 2 later on. G-protein coupled receptors are really, really important. You're going to find that this is probably by far and away the most common ways that drugs are going to be interacting with the system here. These are really powerful sort of cell signaling molecules here, but basically you're going to have the G protein kind of sitting here within the cell surface. You're going to have the signal binding site right here. This is where the drug binds to it, and then you'll find some downstream segment here, and this is where we get into the second messengers, and we're going to talk much more about this in the second section, so we'll talk about that next week. But just so you know, this is like the largest family of cell surface receptors that are available, and just as an example, there's like more than 1,000 G proteins just in your nose alone. They're responsible for the sense of smell, so it can cause a huge number of changes here in cell function just by virtue of how many different types of G proteins we have. You're going to find that things like serotonin, an important neurotransmitter for things like mood and anxiety and things like that. There's more than 15 types of serotonin receptors. That's really important because if I activate certain ones, I can use that to treat schizophrenia. If I work on other ones, I can treat migraines. If I work on other ones, I can affect depression. And so based off that, they have very different functions here. And that's when we start to talk about different receptor subtypes. It's important to know those when we get into the drug. So that way I know that a 5-HT, which is a way to abbreviate serotonin, 5-HT2A receptor works differently than a 1B, 1D receptor, works different than, say, a 5-HT3 receptor. We'll get into that. We'll learn all of those things as we go forward, so don't get scared by that now, but just know that there's a lot of G proteins that are out there, and they all have very different functions depending on what tissue they're at and what their composition is. But basically what you're going to find is that when a G protein gets activated by the signaling molecule, you're going to have this activation of the actual intracellular components of the G protein itself, these subunits. This is all going to be energy dependent, so here you have like GDP, guanosine diphosphate, actually picks up a phosphate group and is activated, and it causes whatever downstream signal is going to occur right here. You can see the subunit come into effect, some target protein that may change transcription of genes in the nucleus. It could cause changes in heart rate or blood pressure, whatever the case may be, and then eventually it will then go back to a resting state where it can then be activated again later on. Again, I don't want to get too much into the weeds. We'll talk more about second messenger systems a little bit later on. This is kind of going through and talk more about that. So the third type we'll talk about are the enzyme-linked receptors. This is going to be important when we talk about things like insulin, when we talk about things like cancer and things like that. These are basically receptors that have enzymes linked to them, which that's the name, right? The most important one we're going to talk about are going to be called the tyrosine kinases. If you recall back to your biochem days, kinases just means it adds a phosphate group onto it, right? And so, as I mentioned, tyrosine kinases are the most important drug-related ones we're going to talk about here, and it can affect things like cell proliferation. It can affect things like DNA synthesis. So you can already see why targeting these may be really good for certain types of cancer. If you can stop that cell proliferation, they can stop the cancer potentially. And then, as I mentioned, insulin receptors are another really important example of this as well. And basically what happens with these ones, you'll notice that these are going to have, you're going to have two different molecules here, two different receptors. And as they get bound by signal molecules, they dimerize, they kind of add up together, and then they get phosphorylated, right? It's a part of that kinase process there. So they get this high energy phosphate added on, and then they activate some of these proteins here to cause a cellular response downstream. So for instance, if it's insulin and it affects that signal molecule, it's going to activate the tyrosine kinase receptor, is then going to lead to more glucose transporters being put on the cell surface. I think I have an example of that. Actually, we'll talk about that later. But basically, when you have insulin come along, it's going to cause glucose transporters to be placed upon the cell surface, and that's then going to cause glucose to be sucked out of the bloodstream and lower your blood sugar. Right? That's a tyrosine kinase type of receptor. The last one we'll talk about here is going to be our intracellular receptors. And so these are mainly going to be like steroids and other hormones. They're able to go through the membrane itself. So they don't work at the cell surface. They go through the membrane and then work at the site of the nucleus. So thyroid hormone, cortisol, estrogen, testosterone, all of these hormones are the very common things we're going to see as intracellular receptors, because they're then going to work down on the side of the nucleus, on the DNA, to change transcription, right? So for instance, if I give a patient testosterone, it's going to cause them to start to change those transcription areas in the DNA and cause increased muscle growth. If I give estrogen to a patient, that may inhibit ovulation. All that's related back to its actions on the DNA itself, because it's able to get into the cell and then activate those parts of the DNA. Okay. So as a summary, these are the different types of main drug targets we're going to see when we're talking about different types of receptors here. So just have an example of, or have an idea of kind of what they do at a baseline function. Some of the examples we talked about to kind of illustrate that. We're going to get much more into this. So don't worry if you don't have a full kind of grasp on it yet. This will make more sense when we get into the secondary messengers we'll talk about next week. Okay. So anyway, I'm actually right on time. It was a bit of a whirlwind, but do you have any questions I can answer about that so far? I want to see if there's anything on the sticky board. No questions on here yet. I still have all 30 of you here, so that's pretty good. So everyone's stuck around. So any questions are all I can answer for you. All right, why is IM delivery limited to 3 mLs? That's a good question. Basically, it's more of a pain issue. If you imagine getting into the sub-Q tissue, it's mostly fat and skin. You're going to find that it's relatively elastic. Oh, sorry. Access to the sticky board, you get to that from the site here. So the sticky board is here on the module section of Canvas. But yeah, so if you imagine a sub-Q injection, there's a lot of give there. It's much more stretchable, and so you can actually give huge amounts of fluid via sub-Q administration. I don't know if any of you have animals like dogs or cats, but if they ever go to the vet to get fluids, they actually give it subcutaneously. It's called hypodermoclysis is the term for that. So you can give a lot of fluid subcutaneously, no problem. Not very painful. On the other hand, the muscle, because it's fairly tight and very limited in terms of how much it can stretch, any fluid you put in there is going to stretch that out and cause significant pain to occur. So more than 3 mLs for an adult, it gets pretty painful. So we might either try to split it up into multiple injections potentially, or we might try to concentrate the drug such that it's going to be able to be given in a smaller volume. But you see, like especially in small kids, like we may only limit it to like 1 ml per injection site. Just depends on the age and the size of the patient there. So what other questions can I answer for you? Again, if I don't get questions, I assume I just taught it perfectly and you all have perfect understandings, and so you guys just know everything now, right? Okay, obviously. Just FYI, the best ways to reach me are going to be via either Canvas, or you can email me. My email address is awood2@nova.edu. I think that is on the syllabus, so you can find that there. Messaging through Canvas goes right to my email anyway, so I can find that no problem. Either way, it works for me. So if you want to ask questions offline, that's totally fine. But yeah, otherwise, I think that's pretty much it for me. So if you want to log off, go ahead. See, I have a question here from David. In regards to OTC meds, is there a way to determine efficacy of different brands or racemic mixtures? Is there more reputable brands that are worth an additional cost? That's a good question. So for over-the-counter meds, and we'll talk more about this later on, but for over-the-counter meds, they're beholden to the same FDA regulations as any prescription product would be. So no, they all work exactly the same. They're all reputable. The Equate brand should be just as good as the Costco brand, should be just as good as any other brand, right? Because they have to show that bioequivalence. If they don't show that, then they can't put it out in the market, right? Where things get sticky is going to be when you start dealing with things like herbal supplements, dietary supplements, and things like that. The FDA doesn't have a lot of strict overview of that. And so because of that, unless there's a safety issue, they really don't put their influence into things. Basically meaning that, people can say whatever they want. They can say it contains this much witch hazel or this much St. John's wort, and there's no real way to regulate that. So unfortunately, that's where it becomes a bit more of an issue, right? We'll talk more about herbals a little bit later on. But looks like Katie asked, are any apps you recommend we begin getting familiar with? So I personally like LexiComp. So through your library access, you should have access to UpToDate, I believe. If not, I'll try to find you a link for that. But basically, if you go through the library website, go to UpToDate, and then through them, you can just type in a drug name, and that will take you to a product called LexiComp. And LexiComp is what I like to use my drug reference. Some people like to use Hippocrates. There are many websites and apps that are out there that are totally fine, that are pretty reputable. They're available to you. So I recommend using those. Okay, what is the best way to go about studying for your class? It's a good question. Best way to study, I would say, is going to be, and it looks like I might be timing out a little bit here, but the best I would say is to go ahead and get the concepts down for this class. Is less memorization than it is more sort of getting the concepts down. It'll become more clear to you when we get into talking about like specifics, like the dose response stuff or the pharmacokinetics and all of that. That'll become more clear there in terms of like what sort of concept I want you to get down. This is all still pretty surface level, so kind of get the definitions down. Understand the concepts behind like the different routes and what are the drawbacks, what are the benefits, and things like that. That's mainly what I'm going to be focusing on, at least from this particular section here. So that's what I say for now. See, any other questions I can answer? All right, well, if not, I thank you all for joining me. If you have questions in the meantime, feel free to reach out, and I will talk to you all soon. Thanks a lot. Bye.